Very much. Thank you for the kind invitation to speak. So I'll try to be as quick as I can. I guess the topic of this talk is the late outcome in patients with shunt lesions that we see mostly in adult life and all the complications that are attached to it. So, of course, everybody in the room knows that the problem we're facing is that more and more children with congenital heart disease, of course, survive to adult life, and these patients then continue to develop late complications throughout their life, and this is an ongoing problem that will increase in the decades to come. We will see more and more of these patients in our clinics. And to make the problem even worse, there are more and more adult congenital heart disease patients that reach even older age, exceeding, for example, 60 years of age. And this is data from the Brompton Hospital and Octa-Tutorel published a few years ago. And as you can see, this is the increasing number of elderly ACHD patients. And this not only includes the patient with complex disease, but many, many patients with simple diseases, such as shunt lesions, that are going through our clinics. And Helmut Baumgartner highlighted this issue in an editorial in the European Heart Journal again, and showed that this proportion of patients, elderly patients with adult congenital heart disease, is going to increase over the decades to come. Now, why is this a problem? Well, it's a problem because patients with congenital heart disease, even those who have undergone corrective surgery or intervention, are by and large not cured. They continue to have many, many complications throughout their life. And this includes, of course, things like pulmonary hypertension, heart failure, arrhythmias, hypertension, difficulties when these patients become pregnant, and reduced quality of life. So we are faced with an ongoing problem, and these patients are not cured, of course. And the other thing that we know, as these patients age, they not only tend to accumulate morbidity and complications, but also they tend to generate more costs to the healthcare system. So they are high users of resources in terms of hospitalizations, emergency admissions. They do need interventions on their coronaries. They need electrophysiologic interventions as well in an increasing rate. And this is, again, data from the Brompton that has been published a few years ago, again, showing the increased workload for the clinics in patients with congenital heart disease over time. And as you can see, there is an increased use of resources in terms of outpatient appointments in this population. And mortality, of course, remains an issue in our population. These patients have suboptimal outcome despite all the progress that has been made, and mortality remains considerable in this population. This is data from Toronto that has been published in 2015. I skipped this one. So now, the question then is, these patients have a considerable mortality. They die early and too early, of course. The question is, what from do they die? And there are a number of studies that have looked into this, and the main driver of mortality in this population seems to be heart failure. So it's very topical, I guess, that next year's symposium will be on heart failure. This is the big problem. But there are other issues like pulmonary hypertension, arrhythmia, sudden death, of course, and infective diseases. When we looked at this in the Brompton population, a considerable number of patients died due to endocarditis as well, and again, heart failure, pulmonary hypertension, and arrhythmias were a big issue in this population. Now let's look specifically at these three topics. As you know, our patients present with initially mostly left to right shunt. They have overcirculation of the pulmonary vasculature. There's shear stress on the endothelium. And then we have these patients who develop pulmonary hypertension. If you leave this condition long enough in patients with shunts on an arterial or ventricular level, then these patients will go on to develop Eisenmenger syndrome, that is shunt inversal with severe pulmonary hypertension and cyanosis in this setting. And we also saw very stimulating talks this morning looking at angiogenesis. And I guess in many ways similar things happen in our patients. We have these patients that are exposed to shear stress on their pulmonary vasculature, overcirculation of the pulmonary vasculature, damage to the endothelium, release of mediators, smooth muscle proliferation and migration, and then we have this panvasculopathic disease that we see in our patients where all layers of the pulmonary vasculature are remodeled, and we have vessel occlusion and pulmonary hypertension. And if you leave this condition, of course, long enough and have patients with Eisenmenger syndrome, we do not only see severe pulmonary hypertension, but we also see multisystem disorder with cerebral complication, infections, renal dysfunction, hepatic dysfunction, etc. And of course, it is recognized that Eisenmenger patients have a very much reduced life expectancy of at least 20 to 40 years, and even short-term survival is not optimal in this setting of Eisenmenger physiology. The issue, of course, is that in developed countries, we see less and less patients with Eisenmenger syndrome. This is data from the German National Registry looking specifically at Down patients with AVSD, and as you can see, depending on the era or the decade of birth, very few patients that are born in the current era in developed Western countries will develop Eisenmenger syndrome. We still have, of course, patients that we inherit from previous decades, but this is maybe a diminishing problem in our population. What is very important to the patient with shunt lesions is, and I think this will become a bigger issue in the future, is patients who develop pulmonary arterial hypertension after defect closure for example, VSDs or ASDs, etc. And we know that these patients have a very poor prognosis. This is data from Alessandra Mannes, published in the European Heart Journal in 2013. So this is the Bologna group. And what they have shown is that these patients with pulmonary hypertension after shunt closure have a very much reduced life expectancy, and even worse than Eisenmenger patients. And the other question is, how many of these patients with congenital heart disease after shunt closure will develop pulmonary hypertension? There are two studies to inform us on this topic. One is from the Dutch National Registry, and what they did is they studied 1,800 patients with shunt lesions and evaluated them for pulmonary hypertension, and they found 7.4% of these patients to have pulmonary hypertension. And as you can see from this graph, with increasing age of these patients, a growing number of these patients will develop pulmonary hypertension. And even patients with relatively simple defects, such as ASD2, closed early in life, had an increased risk of developing pulmonary hypertension late in life, and even at older age, over 40 years, they then develop late pulmonary hypertension. So this is an issue in our patients, and I think it's a growing complication. And we did another study to sort of reproduce this Dutch data with the National Registry in Germany to look at the contemporary prevalence of pulmonary hypertension in congenital heart disease. Again, a retrospective study, and we screened the entire data set of the National Registry, which is almost 50,000 patients. And only patients with isolated ASD, VSD, or PDA were included. Only patients over 16 years of age were included. And only patients who had previous surgical or interventional closure of their defect were included. And we did exclude patients with genetic syndrome who we know are more prone to develop pulmonary hypertension. And of course, then we look for pulmonary hypertension, both taking invasive data, but in most patients we had to rely on non-invasive measurements such as echocardiographic data, unfortunately, because invasive data was not available. And this is the result of this study. Relatively young median age of this population, but you can see considerable number of patients have pulmonary hypertension, ranging from 3 to 5% in this study, despite having simple isolated defects developed pulmonary hypertension. And of course, those patients who had pulmonary hypertension were more symptomatic compared to the non-pulmonary hypertension patients, and the risk factors for pulmonary hypertension were, of course, growing or increasing age at follow-up, but also, not surprising, age at repair was a risk factor, so the later these patients were corrected, the higher the risk for pulmonary hypertension. So I think there is a point to make here. We see considerable number of patients with simple defects and shunt lesions who develop pulmonary hypertension after shunt closure. Their survival is not good, as illustrated by this Bologna group. And we know that advanced therapies or modern therapies that we can offer in these patients improve symptoms and maybe have an impact on prognosis. So I think the take-home message from this is we should not regard these patients as cured. We should not discharge them from clinics because they have an increased risk for pulmonary hypertension. What about arrhythmias? Of course, we understand that patients with congenital heart disease are at increased risk for arrhythmias. There are many substrates for arrhythmias in our patients. We have myocardial fibrosis. We have patches in these patients. We have dilatations of the chambers of the heart. We have electrical disturbances in these patients. And this mechanism, this mechano-electrical interaction, leads to a vicious circle that in many ways in these patients will trigger arrhythmias in this population. And again, this is just to illustrate from older study the macro-reentrance circuits around patch material or suture lines in these patients that then can, in the worst case, lead to ventricular tachycardia or ventricular fibrillation in these patients. Unfortunately, as you all know, we are not very good at risk stratifying these patients for primary prevention ICDs. We do have some markers, including the broadened QRS durations, for example, in the Fallot patients, or QRS fragmentation more recently as a marker that has been published. But in isolation, this marker is insufficient to warrant ICD implantation in these patients. And even some risk score that have been proposed, this one is the so-called CARI score that has been proposed from the Boston group a few years ago specifically for Fallot patients, is not very accurate in predicting sudden cardiac death in our population. It also relies on invasive measurement of left ventricular end-diastolic pressure. So there's a lot to do in this setting to prevent sudden cardiac death in these patients. I think one issue that has been emerging over the last years, we have recognized that we have to fix hemodynamics first to avoid arrhythmia. So there's an increasing number of patients with, for example, Tetralogy of Fallot, but also other conditions that are undergoing valve replacement, for example, to fix primary regurgitation in this setting, to have a better hemodynamics to reduce the risk for arrhythmia. At least this is the idea. And of course, the novel strategies, the invasive strategies to implant valves reduces the threshold to some degree to do hemodynamic intervention in these patients. But I think this is, again, very important in our population. Arrhythmia is a big issue, but it's quite often triggered by hemodynamics. Unfortunately, this is, again, expert consensus in many ways. There is no solid data to confirm that if you fix hemodynamics in these patients, you will reduce the risk of sudden cardiac death in this population. But of course, these studies are very difficult to do to match these populations. For now, we have to rely on our clinical judgment. Another big issue, of course, in our patients is the supraventricular tachycardia that we see in many patients with congenital heart disease, including the very simple defects like the atrial septal defect. And this is data from the Münster group that have looked into this and in patients with ASDs. And what I wanted to point out to you, of course, these patients don't present with the normal isthmus-dependent type of atrial tachycardia. Many of them have atriotomy or scar-related re-entry tachycardias in these populations. And the ECG presentation may be unusual in this population. But the important message, I think, from this is that these patients have a high burden of supraventricular tachycardia, and we should try to be relatively aggressive in this population. And wherever we can, we should not rely on antiarrhythmics. We should refer these patients for electrophysiologic investigations, because many of these atrial tachycardias can be fixed in a way. There is some recurrence rate, of course, but we can address them mechanistically in these patients. Now, last topic that I was asked to point out, to speak about, is the issue of endocarditis, which of course is a very big issue for our population. It's associated with high morbidity and considerable mortality even to this day. I want to pick one study that is relatively recent, looking at the risk or the prevalence of infective endocarditis in adults with congenital heart disease, again from the Brompton population. This study included all episodes of endocarditis at the Brompton Hospital using modified Duke criteria. The authors were able to identify 164 episodes of endocarditis in 144 patients. And you can see the age of presentation was relatively low in this population, around 30 years. And a considerable number of patients had simple defects in this population, so simple shunt lesions, ASDs, VSDs maybe, in this population. And interestingly, a predisposing event like a visit to the dentist or other interventions could be identified in only 26% of the patients. So this is the outcome of these patients, and as you can see from the numbers up there, the mortality is still considerable. Even in the current era, almost 7% of these patients died, and as you can see, many of them died in hospital. Many of them had to have emergency surgical reintervention, and even of those patients, some died. So it continues to be a big issue for our patients. One big issue that we are also interested in is about endocarditis prophylaxis, I guess. And as you know, around 2007, 2008, the guidelines changed, became more or less liberal prescribing endocarditis prophylaxis. So one of the interests in this study was to see whether this made a difference in the incidence of endocarditis in this population. And if you look at this plot here, you cannot really see a change in the occurrence of endocarditis in this study. So in this sense, it seems it's slightly reassuring. It seems that the change in the endocarditis guidelines being more restrictive with administering this endocarditis prophylaxis didn't seem to have led to an increase in the risk for endocarditis in this population. The other thing that I wanted to highlight very briefly is this is based on this study from the National Register in Germany, where they actually asked patients with congenital heart disease how much they know about their risk for infective endocarditis, because of course if you want to do something about this, if you want to be proactive in selected patients to give endocarditis prophylaxis to avoid maybe unnecessary interventions on the skin or bacteremias in these patients have to be informed. So they asked almost 1,500 patients about their knowledge of endocarditis, and I think to make a long story short, the results were not very good. The majority of patients didn't know what endocarditis is. Even some of the patients who said they wouldn't know what endocarditis is didn't actually know. So there is a lot to do for us in this setting. We have to educate our patients, and we have to discuss this issue with the patients very thoroughly. So to conclude, I think, of course, congenital heart disease is a success story, but we have to keep in mind that the majority of patients are not cured. There is high ongoing morbidity and mortality in this population. Pulmonary hypertension remains a major issue in these patients, and it can occur even years after defect closure. So I think there is a point for lifelong monitoring of these patients. Arrhythmias are an important cause of morbidity and mortality. And I think there is, again, a strong case to be aggressive with catheter ablation in these patients whenever it's possible. But, of course, as a first step, we have to address the hemodynamics. And endocarditis, unfortunately, remains a concern. And we continue to recommend endocarditis prophylaxis in selected patients, but of course we have to be aware that the data is not very strong on this. Thank you very much.